Okay, my name is Ian Rummery. I am a mental health team lead and community psychiatric nurse for the island of St. Helena in the South Atlantic Ocean. Briefly, St. Helena is a British overseas territory, population just over 4,000, kind of halfway between Africa and South America, very remote. A weekly flight if it gets here, though last week's flights only turned up yesterday. Because the wind was a bit blowy. It's quite a difficult place to get to. So as I said, I manage the mental health team. So the mental health team on St. Helena is 3 community psychiatric nurses and a support worker, like a healthcare assistant. We have then a psychiatrist who's based in Scotland. So we have remote support from her, which is every 2 weeks we have sort of a virtual ward round, and then we're in email contact, and she will see patients for us. Previously, we had, for the last 5 or 6 years, we had a psychologist on island. We've now made the decision because of the difficulties in recruiting, so all of our psychology services are remote. We have a main counselling psychologist based in Cape Town who sees on average about eight patients a week. And then we use other specialists as required. That's where I am. We are literally cradle to grave in terms of what we do. So we see everything from people in emotional distress following the breakup of a relationship, right through to people with quite severe mental health issues, and a particular sort of specialty or particular interest of mine is forensic work. So in the last couple of years, I've developed the police custody system. So we now have quite a robust police custody health assessment service. And I also act as the prison nurse. And in the prison, we do both physical and mental health. So it's very likely, because I've just seen someone in police custody who's probably going to get remanded to prison this afternoon. It's very likely that when I finish here, I'll go back down to prison to then book him into prison.
And that's how we, sorry to interrupt you, Florian, but that's how we met, isn't it? Through that forensic interest. So Ian and I have met before. I'm Rachel Forbes, consultant in public health and assistant director at North Lincolnshire Council in England. We met through the Global Law Enforcement and Public Health Association, through Nick Crofts, who's the exec director, introduced us because he's aware of the work that I've been doing with Rachel Westbourne on social love, and also aware of the work that you've been doing on St. Helena, which is very similar and has so much crossover. So we've had a chat before, and that's when I knew that we needed to speak to you and record it so that other people could hear about what you're doing, and also about how what you're doing is really relevant to social love and public health. So tell us a little bit more about the prison system, just because I'm really interested to hear it again. And
it's a very old prison. It was built in 1826. It was condemned in 1850, and we're still using it. It's very small, very cramped, smack in the middle of town. Having said that, it's quite, I wouldn't go so far as to say it's therapeutic. However, because it's a very small prison and because it's a very small community, it's also a very relaxed, not relaxed is the wrong word, but it's a very calm prison in that respect. So I have, in the 5 years I've worked there pretty much continuously as part of my other work, I've witnessed 2 episodes of violence. And both of those were very, very low level. I've never felt threatened. I can walk around the prison unaccompanied. I can pop in and out and see prisoners. Our prison capacity is around about 25 at the moment. It's around about 18. Of those 18, off the top of my head, I would say 12 to 13 are sex offenders. We have a number of people with historic sexual offences dating back 20 or 30 years that were only imprisoned in the last year or two. So the island is always on a bit of an edge, like we don't have enough staff at the hospital, we don't have enough staff at the nursing home, we don't have enough staff in the police. So we're always struggling, and can become quite difficult because obviously, because we are quite, in the sense that we are quite British and we are quite I don't know how to say this, law-abiding in that respect. So, for example, we don't cut corners. So even though, you know, our judicial system is really quite robust. So even though we might be short of police and we might be short of that, there's you know, they still do their job. We've recently had a guy who's managed to successfully sue the prison, and it's in the public domain now, because we don't really have an exercise area in our prison. There are some significant concerns about fire risk, and he's successfully sued, and I don't know what kind of pay he's going to get. And yet, if you said to me, Ian, you know, we're going to put you in prison and you can go to HMP Jamestown and St. Helena, or we'll send you to Wormwood Scrubs, I'm coming to Jamestown. You know what I mean? It's, you know, when I compare, and yes, our conditions are not great. We're not at all minimising the difficulties of our prison. But when I hear some of the stories about UK prisons, or Australian prisons for that matter, you know, I think, yeah, the infrastructure is very poor. But the actual care and welfare of the prisoners is really quite important. And that's the same in police custody.
Yeah. So despite all of the challenges that it sounds like can come in living on St. Helena with the small and ageing population, being kind of quite isolated in some ways, there's still something that has allowed a really kind of like positive and safe culture in some aspects to develop. And
yeah.
What do you think it is that has helped to promote that?
I'm not sure. I mean, it's difficult because, like I say, I've been in police custody today, and it's unusual that we get 2 arrests in one day, but they're both for sexual assault. I think there's a couple of things. I think one is that a good portion of our, let's be honest, most offending is 18 to 25-year-old males. A good portion of our 18 to 25-year-old males are just not here. To the north of us is Ascension Island, which is nominally a UK overseas territory. It's effectively an American Air Force base. And so lots of people go there to work, and obviously lots of people go to the Falklands because there's loads of money on the Falklands. So I do think that the St. Helenian male culture, and I got to be careful because there are still very high rates of sexual assault, is not the macho culture that I would expect from an Australian country town, for example. So anecdotally, I think we have fairly low levels of violence. So, you know, I'm pretty sure in an Australian country town, every Friday, every Saturday night, at closing time of the pubs, there are just people brawling in the streets. You know, it's just kind of a common thing. It's very rare that happens here. So I think it's not a particularly violent society in that respect. We're also lucky in that there's no real drug problem here, simply because it's just too hard to get. You know, there has been some. We are thinking there might be some fairly novel drugs that come in because there may or may not, 1 or 2 people may or may not have drinks spiked in the last couple of weeks. We're not really sure what's going on there. But you know, if you couldn't maintain a cocaine habit on St. Helena, for example, because you just couldn't get the supply. A lot of marijuana, a lot of cannabis is smoked, and there's a small sub-reggae culture on St. Helena. But what's different about us? It's very hard to say. Yes, we're a very small community. I think that the interesting thing, I would also say that St. Helena is probably the smallest, I want to say, society, remote society in the world, because if you look at
more about the work that you've been doing.
Yeah. So yeah, I might be the psychiatric nurse, and yes, I do all things psychiatric nurses do. So I give medications. I'm not a therapist, but I'll do kind of basic counselling, whatever. I'll also take people shopping. I'll also organise doctor's appointments for them, go to doctor's appointments with them. You know, I had a phone call this morning. I got a phone call first thing this morning because one of my used to be in prison ex-patient has a bit of a drinking problem, wants to come into town for Christmas. I'm going to pick him up tomorrow morning and bring him into town. I'm also going to make sure I take him out of town before the end of lunchtime. Otherwise, I'm pretty sure he'll be drunk and then probably get himself arrested. Or what will happen is the police will ring me and go, we really don't want to arrest him, so can you please just take him out of town for us? And I'll drive him back to his place in the government vehicle. After getting called into police custody this morning, I then had to drive out to pick up a patient to bring them in so they could sit literally at this computer and have their counselling session with the psychologist in Cape Town. There's no public transport. We got him in on time. He doesn't have enough money. As far as I'm concerned, I'm not just picking him up and driving him here. I'm also having a conversation with him. We're also having a chat about, because he's someone who has disclosed, so he's disclosed some historic sexual abuse, and 2 people have been arrested. And so we're talking about that case while we're driving in. So we do a lot of those kinds of things, which to me are absolutely vital to building the therapeutic relationship. I would, and I think I said this to you, Rachel, I would really struggle if you put back in the NHS, because I break boundaries all the time, in terms of visiting people at home, chatting to them at home, taking them shopping, having coffee with them, bringing their mother in to see, I don't know, just all sorts of different things that we do that aren't technically psychiatric, but I think build that whole relationship.
You're taking you'll have heard of the building blocks of health, or the wider determinants of health. So when we think about the building blocks around housing and transport and family and friends and community, you're sort of enabling all of that. So when people need their building blocks strengthening to be healthy and live a good life, you don't just look at the one thing. You're not siloed. You're working across the whole spectrum of what a person needs. And that to me is just exactly what is needed everywhere. I don't know. What do you think, Rach?
Yeah, it sounds like sort of a truly holistic approach, which is, a concept that we have here and talk about, the idea of holistic care and addressing people's sort of wider circumstances as part of their, like, trying to improve their health outcomes. But it sounds like you're doing that in like a really genuine way. You are not segmenting off someone's kind of treatment from the rest of their life.
Yeah, and I think, I'm very clear, and I don't know whether this is just because I happen to be the mental health team leads, and because it's a small team, I can kind of influence it. But I am very, very clear that we have a literally open door policy. So you walk up those stairs, if we're here, we'll see you. And I struggle, I don't know who's going to hear this recording, but I do sometimes struggle with our social services department, because they will insist on a referral, and they will insist on a form, and they will insist on this, and then they've got to wait for the case to be open and someone allocated. I can't be bothered with that bullshit. If you're in distress, we're going to come and see you. Yeah. And I think, so when, and we've just had a new CPN come from the UK, and she's fantastic. And what she said to me was, when we interviewed her, was she said, you know what, I'm sick of working in the NHS and being told I've got 6 sessions and that's it. And if they come back for the 7th session, I've got to re-refer them. I said, look, you can do what you like, in a sense. You can do what you like with your patients here. So what she's discovering is, because she works with some of our more troubled younger people, is, she can go for a walk in the forest with them, or she can take them for an ice cream, or she can do this kind of stuff. And there's no pressure to finish the work. Because, yes, we are busy, and we are, we're all working 40 plus hours a week, and someone's always on call. But we're also not overwhelmed by the numbers of people.
Just on that point, on that, the permission that you've given there to that member of staff, you're providing the freedom for people to know, to do what they know is the morally right thing for the good of that person. And I think that's one of the linkages with social love that really sticks out for me, because social love's all about decision making. We've explored it in a public health context and at a population level, but what you're doing is at the individual level, and it's all about decision making for the good of another person, for a community, for the environment. And that's exactly what that is. It's the right thing for that person to take a young person for an ice cream and go for a walk, rather than have them in a stuffy office talking about value. It's like you focus on value, not process, and on outcome, not process. And that's something that we talk about sometimes in the UK about, doesn't matter what hours you work as long as you get the work done, but then it does, because the policy says that you've got to do X, Y, or Z, and if you're not doing that or filling in your flexi form, like you're potentially in trouble. Bit of a simplification there, but you're treating your staff and the people that you work with like human beings who have a wider life that impacts on the reason that you're interacting with them, whether that be as a manager or as someone that's supporting them, or as someone who's giving them help when they're in prison. I mean, what are you thinking about the, from what you've heard and read about social love, because I know you've seen the paper, what has stuck out for you when you've been thinking about the crossover between the two, and how what you do is similar or different from what we were talking about?
Psychiatry, I think, and mental health lends itself to this kind of thing. So, you wouldn't be able to have this kind of attitude if you were the theatre team, because, you all need to rock up at the same time, and you need to, it's very task oriented. So I'm well aware of the fact that I'm lucky I'm working in an area where it's all shades of grey. There's no real black and white in mental health, and that was I suppose when I read the social love literature, it's how much of this is dependent on individuals doing what they do because they're passionate about what they do, and how much of this can be institutionalized, for want of a better word, or formalized. But then if you formalize it, are you losing that aspect of social love? I don't know. That's the bit I'm not sure. How do you, how if you whatever the word is, policyfy it? If there's a policy on social love, have you then taken the guts out of it? I don't know. That's the bit I'm not sure. Or do you then create an environment that allows people to be more flexible and more autonomous? Is that the way you do it? And not everybody will do that, obviously, because we're all different. I don't know. I mean, that's the thing for me.
I think you've brought us to a really good point, Ian, and I could talk to you about this all day. What you've just said there about do you lose the social love bit? I mean, for us and in our definition, there is some affect in there. There is some emotion in there, and like you said, if you have a framework, do you create the conditions in which people can make those decisions? And actually, in a later recording, Rachel and I are going to be talking to some people from North Lincolnshire Council who are actually doing a lot of this already. There are lots of organisations in the UK that we're coming to hear about that aspects of their work are socially loving. They're making decisions and putting them through the filter of, is this in the best interests of this person, as well as the community, as well as the environment? And that's what we're after, really. And I think you do that, but it isn't formalized. And I'm really interested in how that formalization would affect or could affect what you do.
Rachel, I think that's a really kind of good conclusion, like a good concluding reflection, I suppose, because for us, I think partly because of the system that we're working in, policies and processes do determine so much of what happens, and they kind of almost set the scope and the boundaries for what can happen, for the culture that follows, for how the workforce behaves. And so that feels like a really important thing to do. And we think that a lot of our policies and processes and systems at the moment probably aren't socially loving, or don't allow for like the promotion of a socially loving culture and environment. So we've been trying to think about how do we alter them so that they would promote that. But it's really interesting to think about, if you do try and formalize some of these things, what might you lose as well?
Where do you, how do you make that a system that's both flexible enough so that we can do the social love stuff, but also has significant safeguards, that it's not just a free-for-all?
I was going to say, it's trying to reach that balance, isn't it, between the sort of safeguards that we absolutely need in place, but also allowing a flexible and an adaptive approach, which it sounds like is what you and your team really have. You can be adaptive and you can be flexible to meet whatever the needs of the patient. are, which is really important for actually providing that holistic care that addresses social determinants that we were talking about. You can't do that if you're working really rigidly, but obviously you do still need certain safeguards, certain safety procedures still in place. And it's interesting to think about, how do you find that right balance?
How do you develop that system that allows these relationships to develop, but still safeguards so you don't have people taking advantage? Because let's face it, all of the people I work with by definition are vulnerable. But how do you give that freedom to, as you said, make those social love decisions?
All right. Thank you, Ian, so much for talking to us again, talking to me again, and talking to us together. It's been really interesting, and I love